We're going to do a lot of talking about diabetes today, 2 different lectures on diabetes. So get ready for all you need to know in about a half an hour of conversation. So basically, we're going to try to detail the scope of the problem. We're going to talk about some of the adverse outcomes of hyperglycemia and why we think this is an issue. Then go over a few of the controversies that have happened over the last decade or so in terms of the control of glucose in the hospital, tight versus not tight glycemia control. Evaluate some of our treatment options and talk about how to manage these patients pre-op and in the non-ICU areas. So let's start with a patient. So we have a 58-year-old obese woman. She has type 2 diabetes. She's admitted for treatment of an infected diabetes-related foot ulcer and noted to have chronic right foot osteomyelitis. Her foot's a mess. She's found to have significant vascular disease and is scheduled for a lower extremity bypass. And the surgeons have requested that she be kept NPO after midnight. So they call in the Gen Med consult service or the endocrine consult service and ask, what should we do with the diabetes? Her weight is 100 kilograms. I'm sure she sounds like many of your patients. Her blood glucose levels are usually in the mid-200s at home, and she has a beautiful A1C of 11.2%. And her home medication regimen, which may or may not be working so well, glipizide, metformin, and then she's on a 70-30, about 15 units BID of 70-30. Her last blood glucose was 292. So we're going to end up talking about before surgery, how should we manage her diabetes, and then transitioning to the floor, how can we manage her diabetes and while she's on the floor. But before we do that, let's go over the scope of the problem. About 8% of Americans have diabetes, which in 2010 was about 23.6 million people. We're probably up to 25 million people by now, and it just continues to grow. There are 5 million patients discharged per year with a diagnosis of diabetes from the hospital, and it accounts for about 22% of all inpatient days. And inpatient care accounts for about half of the $174 billion that we spend every year in diabetes care in the United States, and this is as of about 2010. So that's probably gone up as well. Just quickly to remind ourselves, how do we diagnose diabetes? Well, if you have a patient who has been fasting for 8 hours and is found to have a glucose greater than or equal to 126 milligrams per deciliter, and you repeat that and they have that again, they have diabetes. If they have an A1C that is greater than or equal to 6.5% twice, then they have diabetes. And remember, it could be lower. They may have a hemoglobinopathy, some form of anemia. Some of those patients have A1Cs that look normal, but they still have diabetes. If you have classic diabetes symptoms and you do a random glucose check twice, and they have a glucose greater than 200, you have diabetes. And if you do a oral glucose tolerance test with a 2-hour plasma glucose of 200 milligrams, you have diabetes. And I don't think too many of us are doing the oral glucose tolerance test too often. And so you have your patients who you're going to diagnose with diabetes, but you also have your patients who come in with the stress hyperglycemia. And that's going to happen whether you're dealing with patients in the perioperative period or patients who are just medically ill when they come in. Stress hyperglycemia is a common problem. And these patients who have stress hyperglycemia, many of them eventually develop diabetes as well. How do we know that? Well, here's a very recent study where they looked at 2,000 patients who came in with pneumonia to an academic center, and they looked at, for all of those 2,000 patients with pneumonia, they looked at what their blood glucose levels were when they were admitted. And many of the patients had normal glucose levels when they came in, or mildly elevated glucose levels when they came in, 110 to 140. And most of those patients, if you look over a 5-year period after they had their pneumonia, 93% of those patients did not develop diabetes. Only about 7% did. But if you came in with a blood glucose level of 200 to 360 and you had never had a diagnosis of diabetes and you came in with that high glucose with your pneumonia, over the next 5 years, about 50% of those patients were going to be diagnosed with diabetes. Which means if you are looking at a number needed to screen, if you have a patient who comes in with pneumonia, and I think I feel fairly comfortable extrapolating it to lots of other stressful areas in medicine, if you come in with that hyperglycemia, all you need to do is screen 3 of those patients for the next 5 years, and you're going to find at least one of them who has diabetes over that period of time. So many of your patients who don't have diabetes but come in with severe hyperglycemia from stress are going to develop that diabetes. Another opportunity to make the diagnosis of diabetes. And we know that hyperglycemia, whether it's from diabetes or whether it's stress hyperglycemia, is problematic for patients in the hospital. Dr. Golden from Hopkins looked at 411 patients who were undergoing CABG and stratified them based on what their glucose levels were and found that the lowest quartile had the least likelihood of developing a surgical site infection, and the ones who had the highest quartile were the most likely to develop the infections, and none of this surprises any of you here. And there were lots of observational studies that told us that having hyperglycemia was dangerous. Here, about 1,900 patients who were newly diagnosed or known diabetics had a higher inpatient mortality rate versus the normal glycemic patient. Another study with mixed ICU patients showed that the hospital mortality increased progressively with the increase in glucose levels, and I'm going to show you what that looked like in a second. And then finally, glucose levels greater than 145 increased mortality in another mixed ICU setting. And there are many, 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 many more of these observational studies that I could show you that show that having hyperglycemia is associated with having worse outcomes. And all of us were beginning to believe hyperglycemia is not necessarily a healthful thing when you are in a hospital setting. But the question is, what do you then do about that? Here's that Mayo study just showing that your in-hospital mortality increased by 2 times when your blood sugars were in the 120 to about 200 range, about 3 times from baseline when you were in the 200 to about 300 range, and then 4 times increased over baseline when you're over 300. The numbers were very, very impressive. So we started to try to figure out, can we actually lower the risk by treating these patients? Because if we can't actually lower the risk, well, then maybe we shouldn't really worry about having hyperglycemia. So Griet Vandenberg did a study in her ICU in Belgium where they looked at about 1,600 patients in the SICU. And they wanted to look at these patients to see if they could control them in a very intensive way. So they had an arm that was a conventional. If your blood sugar was greater than 215, they were going to target you and they would start the insulin and they would target you to try to get a glucose somewhere between 180 and 200. And then they had a second arm where they were going to be really intensive. So if your blood glucose actually got over 110, they would start the insulin, and they were trying to get you down to a very normal level of 80 to 110. And this appeared in a regional journal called the New England Journal of Medicine. And this was very exciting because it had some great looking outcomes. The mean glucose for the conventional group was 153. The intensive group, they got them all the way down to 100. They absolutely were reaching their goals. The percent of patients who were receiving insulin, not surprisingly, if you were in that intensive group, 100% of those patients ended up getting some kind of insulin. But there was severe hyperglycemia, glycemia that usually is termed severe if it is less than 40 in the literature, and 39 patients in that intensive group, as compared to 6, had severe hyperglycemia. But the results seemed to be fantastic in terms of survival in the ICU, about a 3% absolute difference for the patients in the intensive group versus the conventional group. And then if you look at in-hospital survival for those patients, again, really, really convincing evidence that the patients who had that intensive treatment did much better for the entire hospitalization and left the hospital as compared to the patients who had the conventional treatment. It appears in the New England Journal. Everyone begins to buy into this. This must be the way that we treat our patients. So then we said, well, maybe we should try it in the intraoperative period. And so there was a study done of about 400 cardiac surgery patients who were randomized to intraoperative intensive therapy versus conventional therapy during the actual surgery. They all had intensive therapy after the surgery, but they didn't find any difference in morbidity and mortality. And then some other studies started to come out where it didn't look like the intensive therapy was actually as good as it looked in the Vandenberg study. And so we said, well, maybe we're not actually knowing what we're doing here, even though the results look so good in that original study in the New England Journal. So, and in fact, in this study from Gandhi et al., the patients seemed to actually have an increased incidence of stroke in the intensive insulin treatment group, and there were 4 deaths in that intensive group. And this starting to add to the other literature that showed that maybe we weren't as right as we thought we were about this intensive insulin, led to a large study called Nice Sugar, which came out in 2009. Now, Nice Sugar was a mixed ICU population, both surgical and medical patients, and again looked at an intensive arm versus a conventional arm. This time the conventional arm started the IV insulin with a blood glucose of greater than 180, in the intensive arm greater than 110, and you can see that they were aiming for about 81 to 110 in the intensive therapy, and in the conventional about 140 to 180. And the results were pretty surprising, because the patients in the intensive therapy group did much worse, and statistically significantly worse. And at 90 days, about 27.5% of the patients in the intensive glucose group had passed away, as compared to only 24% in the conventional group. The conventional group had less mortality than the intensive group, and that also held true at 28 days. Now, it was not statistically significant at 28 days, but the same trends were seen. And the biggest trend was the severe hypoglycemia again, the sugars less than 40, where about 7% of those intensive patients had sugars less than 40, severe hypoglycemia, as compared to only 5% of those in the conventional group. And so now we have severe hyperglycemia paired with increased mortality, and intensive therapy doesn't look nearly as appealing. And if you look at the subgroups, so maybe it's the subgroups that we just need to look at, and we'll find the patients who actually really do well with the intensive therapy, and even looking at the subgroups of patients with severe sepsis or trauma or really high Apache scores, no one seemed to do better with the intensive therapy in the Nice Sugar study. So if high blood sugars predict mortality, why would tight blood glucose actually increase mortality? And the thought is that maybe this hypoglycemia is actually evoking the same sort of stress responses we're seeing in other settings. That's increase in the catecholamines, the cortisol, all the stuff that you saw Dr. Dorman talk about in the first lecture here. And maybe that's actually resulting in deaths, primarily to excessive cardiovascular mortality. And so when you start looking at all of these different studies together to see what the meta-analyses, the systematic reviews show, both in the ICU studies and in the non-ICU studies, the systematic reviews show that the intensive insulin therapy is not better than the conventional insulin therapy that many of us have been using for the time before 2001 Vandenberg study. And certainly the systematic reviews show that if you use intensive insulin therapy, you are very, very likely to develop severe hypoglycemia. So what should the glycemic goals be? How tight is too tight? How tight are we talking? This may be too tight. This may be too tight. And so that, I would say, is less than 108 milligrams per deciliter. That's probably too tight. So we probably should be relatively loose. And many of the organizations that have a stake in hyperglycemia have come out with their guidelines about treating hyperglycemia and what your goals should be in the hospital setting. The ADA, AACE say the critically ill should be between 140 to 180, non-critically ill, fasting less than 140, randoms less than 180. The ACP, a little bit more loose, they're in the 140 to 200 range. And the STS has some other recommendations, but all within that same sort of area of the 140 to 180 range. The ACP's guidelines in 2011 basically said, recommending against the use of intensive insulin therapy to strictly control blood sugar in the non-ICU patients with or without diabetes, and recommends against using intensive insulin therapy to normalize blood sugar in the SICU patient and MICU patient with or without diabetes. And they recommended their targets of 140 to 200 if you are going to use insulin therapy. But some of the things that are not answered here are there subgroups, particularly the patients who are going for bypass? Are there some subgroups that actually do better with intensive insulin therapy that we need to keep studying? But at this point, we can't really say for sure that anyone really does better with intensive insulin therapy. So how do we reach the glycemic goals then of that 140 to 180 safely? Well, we all know that in our own bodies, when everything is working correctly, we all have insulin that is being secreted all day long by our pancreas, and that there are times when you are having a morning parfait, for instance, that you will have an insulin spike that goes up as you have your breakfast or your lunch or dinner, but that you have a basal amount of insulin along all day. And what we've tried to do in many of our therapies is just mimic what our pancreas does. And here are some of the insulins that we try to use to do that. Some of the long-acting insulins like NPH, dedamer, and glargine. You can see that for dedamer and glargine, there's less of a peak as compared to NPH. And you can see how it lasts sort of all day long to give you that basal insulin that your pancreas would be providing were it working correctly. And here you can see us using some of the shorter acting insulin, the Lispro, the Asparts, and you can also see regular on there that doesn't peak as high and lasts much longer than your Aspart and your Lispro. Many places don't use regular insulin any longer because the fact that it lasts so long, and particularly in patients if you have any renal insufficiency, that regular insulin begins to stack and last longer and actually can cause some problems over time. And I have a little table here about the pharmacokinetics of the insulin preparations for your reference. An important concept to think about when we are trying to decide how much insulin to give a patient who's been admitted to the hospital: the total daily dose. And there are two ways of trying to come up with a total daily dose for a patient who you would like to start on insulin. One is, if they're already on insulin, just count up the amount of insulin that they're already on to come up with their total daily dose. And if they have an A1C that's normal, that they've gotten down to about 7%, then that number, that total daily dose, is the right number. For those who are not already receiving insulin but clearly need it, or if they're on a number of oral medications and you would like to start some insulin in the hospital, these patients, you can try to do a weight-based treatment strategy, often where you're starting from anywhere from 0.3 units per kilogram all the way up to about 0.5 units per kilogram. And you decide whether you're going to use 0.3 to 0.5 based on the likely insulin resistance and just sort of how squeamish you are in general. So if you'd like to lowball it, you start at the 0.3, and I'll show you some data that you're likely to not cause those patients to become hypoglycemic. And if you have some patients who has an A1C of 12% and you are dead sure is going to need a good bit of insulin, you start at that 0.5 units per kilogram, and that gives you your total daily dose. Now, most of the time we use a basal bolus correctional formula after that, where you take about half of your total daily dose and make that your basal, and you take the other half of that total daily dose and make that your nutritional insulin that the patient gets throughout the day. We'll talk more about that shortly. One of the ways to control glycemia in the hospital is not with oral or other sub-Q non-insulin related medications. I stop all of the oral medications when they come into the hospital. I stop all of the non-insulin injectable medications when they come into the hospital. They are just too difficult to deal with when you're in the hospital. I would not use them. And there's a list of reasons here why they are problematic when you are in the hospital. One of the studies that helped us figure out what to do in terms of how to actually put into practice our insulin treatment of patients in the hospital was this RABBIT-2 study, where they wanted to maintain patients between 100 and 140 milligrams per deciliter. And these were surgical patients who were going to either be on a basal bolus insulin regimen with glargine and a short-acting insulin, or they were going to be against patients who are randomized to the sliding scale, the dreaded sliding scale, 4 times daily. And these were all general surgery patients who were not expected to go to the ICU. Those RABBIT-2 patients, they were eligible if they had a blood glucose that wasn't too high. They had to have diabetes for over 3 months. And they couldn't be on a ton of insulin at home, but they could just be on diet alone or some oral medications for their diabetes. But their total daily dose could not be greater than 0.4 units per kilogram per day, because that's just a big amount of insulin those patients were needing then. And the treatment, they started the total daily dose 0.5 units per kilogram. And again, they used half of that total daily dose as basal and the other half as nutritional. And they started at the 0.3 for older patients or for patients who had some renal insufficiency. Again, more reasons that when you should think about using that 0.3 over the 0.5 units per kilogram. And they switched some of the patients who were on sliding scale to the basal bolus if they weren't doing very well on the sliding scale. And here you can see that they were able to bring down the blood glucose as compared to the patients who were on the sliding scale using this basal bolus regimen, both during the duration of treatment days, and you can look over all of the breakfast, lunch, and dinner glucoses as well. And the complications seem to be a little bit less in that basal bolus group. Fewer wound infections and fewer patients with a total number of complications. But, as you would suspect, more patients with this basal bolus had blood glucoses that were low. Not too many patients who had blood glucoses that were in the severe range, but they did have a few that were in the severe range. So is it tight enough? They had blood glucoses generally ranging from about 145 in the basal bolus to 172 in the sliding scale group. Now here's a study where they actually tried to put into practice, real-world practice, one of these kinds of regimens. And here they used a little bit less. They did the 0.3 for many of the patients and 0.4 units for patients who were already receiving oral hypoglycemics. The 0.3 were patients who were just diet controlled. And they wanted to see how these patients would do in the real world. Again, half of the total daily dose as basal, half as nutritional. And for these patients, again, if you use even the 0.3 or 0.4, you're going to bring the blood glucose down pretty significantly. And on this bottom table, you'll see that the severe hypoglycemia, no matter which group, no matter how much insulin the patients were receiving, happened very rarely, ranging from 0.2% to as high as 0.7%, but pretty low overall. Now, here are some pre-op instructions. This is out of the University of Pittsburgh Medical Center. These are non-evidence-based pre-op instructions, except then they looked at the results of their non-evidence-based pre-op instructions to see how things were actually working, to see if we could make them evidence-based pre-op instructions. And DiNardo and folks found that if you discontinued your oral hypoglycemics on the day of surgery, and that you adjusted their insulin so that they stopped all their short-acting insulin on the day of surgery, and they had their patients who had basal insulin, they had their patients with basal insulin cut their basal by half on the day of surgery. They found that the patients actually did pretty well. About 75% of them following that regimen came in with a blood glucose between 70 and 199, pretty reasonable level. Very, very few of them came in with severe hypoglycemia, or less than 70, moderately severe hypoglycemia, only about 2%. And about 25% did come in with a glucose of 200 or more. But if they followed their standardized care, most of them had blood glucoses that eventually got to that level that we would like to see in that sort of less than 200 range. So this was a pretty good way of having the patients get some pre-op instructions and following it through for their diabetes. I would refer you to that if you're trying to figure out ways of being able to instruct your patients what to do about their diabetes on the day of surgery. Recently, the Endocrine Society recommended discontinuation of orals, just as I talked about, and they recommended using the basal bolus kind of formula for your patients who you were going to treat in the hospital. There are some questions about that I often get at this conference about, are there pre-op area glucoses that are too high to actually perform surgery? And I would say that it, in general, is surgery specific, and particularly, are they having symptoms from their diabetes? Why is their blood glucose so high that day? Is that someone who normally has blood glucoses that are much lower, and now they are having high blood glucoses because they're actually infected, or there's something else going on? Or their blood glucose is only high because they've changed their regimen? I think it all depends on what the actual context for the particular patient is. And does that patient look like they're suffering any symptoms from having glucoses that are that high? And is there an A1C that is too high to then go ahead with surgery as well? And I would say probably not. I probably wouldn't use that as a carrot to then try to get the patient, or a stick to get the patient to then get their A1C lower, but just know that they're going to be dealing likely with some issues with hyperglycemia in the postoperative period. So let's go back to our patient and do a couple of questions. So our patient has that right foot osteo. They need a bypass. They're on 15 units of 70/30 BID. They get metformin and glipizide as well. And the last blood glucose was 292 with an A1C in the 11% range. So what is her insulin total daily dose at this time? What is her insulin total daily dose at this time? Is it 15 units? Is it 30 units? Is it 100 units? How many units do we actually assign glipizide and metformin? Or this counting is making my head hurt. So A, B, C, D, E, which one is it? What is her total daily dose of insulin at this time? Just a check to make sure we got this concept across. And the poll is open, I assume. Can we have the results? Yes, and almost all of you said that her total daily dose is 30 units, which is exactly correct. She's on 15 units of 70/30 BID, which means in a full day she's taking 30 units. And if you were then, let's see if I can move on. All right. So then, if we want to actually come up with a basal insulin dose for her, using a weight-based method, not using what she was on previously, but using a weight-based method, and we will say she is very insulin resistant. And so we talked about some formulas of 0.3 units per kilogram up to 0.5 units per kilogram. If we think she is very insulin resistant, what would her basal insulin dose be? She's 100 kilograms, remember. Is it 10 units, 25 units, 50 units, 100 units, or I prefer sliding scale? Basal, just basal, not the total daily dose, just basal. And let's see the results. Good. So the total daily dose, could we go back? The total daily dose would be 50. If you're using the 0.5 units per kilogram, the total daily dose would be 50, but her basal is half of that 50, so it's 25 units. It would be B because you take half of the total daily dose for your basal. Excellent. So for your preoperative management, hold all the insulin, non-insulin meds, calculate that total daily dose like we just did, either using her 70-30 BID to give you a dose, or using the weight-based dose of the 0.5 units, which give you 50. The basal then is 40 to 50% of that, so about 25 units. And then if you think she's going to be NPO, some people would take even half of that to get her down to about 15 units. And that's a reasonable thing to do. And of course, stop the short-acting insulin except for some of the correctional insulin. You don't want to give short-acting insulin when a patient is NPO. You're just going to buy yourself trouble, and probably check the sugars every 4 hours. So she does well in surgeries, back on the floor. What are her blood sugar goals? All the goals that we've already talked about, that 140 to 180. And the way you get there is, again, just as they did in that Rabbit 2 study, half of the total daily dose as basal, the other half you split into your nutritional. So if half is 25 units, for your nutritional, you would do, say, 8 units for each meal. That brings you up to 24 units in a day. That's right about at half. So pearls, sliding scale insulin alone is not adequate for the insulin-dependent diabetic. You cannot just put them on sliding scale. Use these basal bolus regimens that I'm talking about. Make sure you're holding oral agents, and make sure the patients who are previously receiving insulin receive at least a basal regimen, even if they are NPO. I have a number of pearls in here for you to take a look at about factors associated with hypoglycemia, glucose monitoring issues, which may be helpful to you because sometimes your blood glucose monitoring with the point-of-care testing is not the best. And a recent study coming out of a wonderful institution where we talked about the Johns Hopkins experience. Dr. Barinholtz and Dr. Munoz talk about the experience that Johns Hopkins has at putting together a hospital-wide glucose management program. And if you're thinking about doing that for your own institution, take a look at this and see what our experience has been like. So the summary is there is strong evidence that glucose control impacts outcomes. Populations that benefit from intensive therapy are still being clarified, but in general, intensive therapy is not the gold standard anymore, and that the basal bolus treatment, trying to get you somewhere between 140 to 200, is the standard that we're going with.